I am Fabian Emura. Today is Saturday, July 7th of 2018. We are in Bogota, DC, Colombia, and it is my great honor to interview a worldwide known physician, honored for both his professional and personal accomplishments. He's been recognized for his broad, deep, and sustained contribution to gastroenterology, and it is known as a gastroenterologist of gastroenterologists and a master of masters. Ladies and gentlemen, let me introduce you to, from University of Virginia, Professor David Alan Peura.
Well, thank you very much, Fabian.
So how are you today, David?
Well, a little bit tired. Still, it's, the altitude here in Bogota is a little different than Virginia. But otherwise, I'm excited to be here, and I always love coming, especially to see you.
It is our great pleasure to have you here. I want to start this interview asking you about your parents and grandparents. How did they influence your life for you to be currently recognized as a master of masters and as a gastroenterologist of gastroenterologists?
Well, I think ever since I can remember as a child, my grandparents, actually my grandmother, I never really knew my grandfather, but my grandmother always was telling me how important it was to be honest and forthright. And my parents were wonderful examples. My father was probably one of the most honorable people I've ever met in my life, and I still vividly remember many of the wonderful life examples he gave. And my mother also was responsible really for instilling in me perseverance. My grandparents, or my grandmother and my parents also instilled in me a great faith in God. In fact, at one time in my life, I thought I was going to be a missionary. Mm-hmm. So I had a wonderful upbringing, and those examples, I think, stood me very well later in life. In fact, one of the reasons I went into gastroenterology was because of my mother. My mother had gastrointestinal problems, and I remember those very vividly, so I can really empathize with my patients, having lived with my mother's GI problems over the years.
And I know very well your family, and also Christine, your wife. And I want to ask you something about that. That is your marriage. You've been married for 48 years?
Actually 49 years.
Actually 49?
Almost 50.
So let me ask you, how did you met Christine, and what has been her role in your life in order to accomplish what you have now?
Well, Kristen and I first met in college, in chemistry laboratory. Kristen's maiden name was Patti, and mine was Peura, so we had laboratories together and alphabetically. So we actually met freshman year in college. And I helped her through chemistry. She wasn't very good at chemistry. And one day I was going to actually ask her out on a date. And it was that day she came in, and she had actually been pinned. And pinning means she had a boyfriend, a very serious boyfriend. And so I said, oh, okay, I missed out. But as luck would have it, our junior year in college, Kristen was no longer seeing that boyfriend. Mm-hmm. So Kristen and I met at a conference, a leadership conference in college. And we just hit it off, and so we started dating, and sure enough, Kristen, we got married actually when I was in medical school. Kristen says she helped me get into medical school, which is probably true, the University of Vermont. And when we got married, and Kristen actually worked while I was going to school. She was a speech pathologist, and she drove a Winnebago big van throughout the rural areas of Vermont, giving speech therapy to children in school. And so we continued during medical school, and then residency, and then we had our daughter Jessica, and we had our son Brian. And Kristen, stayed at home. She took care of the children while I was pursuing my career. She's always been there, sort of at home, doing the things that needed to be done to keep the family happy and together. So I probably never could have gotten where I was unless it had been for her, again, her support and ability to be a positive influence at home, and also to be a positive influence to me, always encouraging me.
Oh, that's wonderful. Mama Christine is behind the cameras. Let's give her an applause. Let's move on to the Army times. I know, reading your biography, that you start, fellowship in the Army, the Walter Reed Army Medical Center. But I also know that you arose rapidly from being a regular officer to colonel, and at the same time, in parallel, you became associate professor starting as a resident, but that was quite fast. How did that happen?
Well, the Army is a very unique place. It's an area that I learned a lot. I learned patience. I learned discipline. I also learned to get up early in the morning because that's just sort of a prerequisite in the military. But in the Army, you can advance at a very young age because people don't stay in the Army for a long career. So there are always opportunities to advance. And I was fortunate at the time when I was in the Army that positions opened up, and I was asked to assume those positions of responsibility and especially clinical responsibility at a very young age. And so I just happened to be in the right place at the right time, and I was surrounded by a wonderful group of colleagues, colleagues who not only supported me in my clinical endeavors, but also in my research endeavors. So eventually, when I rose to being a colonel and actually to be the consultant for the Surgeon General in gastroenterology, I made the assignments, and so I could pretty much determine my own fate. And so I chose to stay at Walter Reed and be a senior clinician and also continue my research.
I see. I want to ask you something very confidential, I may say. You were working as a associate professor. You were doing research. You've been international well-known speaker. Also, you were father, grandfather. And dealing with all that situations, it happened that in 1997, Christine was diagnosed with breast cancer. How did you manage that very challenging time in your family and your personal life and career?
Well, frankly, it was a shock. This is not something that you expect. I mean, you deal with, as a physician, you deal with illness all the time, every day. But it really is difficult to deal with it when you're dealing with it in somebody in your own family. I think there are several things that sort of got me through all of this, got us through all of this. First of all, Kristen is a very strong individual. After an initial period of denial, I think she accepted her diagnosis and recognized that she was going to do everything to fight it, and she is cured now. I mean, it's been over 20 years, so we would consider that a cure. But I think we prayed a lot. I think we had a very strong faith. We had support from friends and also from our church community. So I think all of those things were very important, and I guess it brought home the fact that there's more to life than, you know, your career. And as you say, family is important, and there was a period of time where family just had to come first, and you put other things on the back burner. But again, I think had Kristen not been the strong individual that she was, it would have been a much more difficult situation.
David, the next question is about PPIs. For the long-term PPIs therapy, it's been said that, one, without eradication of HP in infected patients, they have the potential risk of development or the promotion of atrophic gastritis and therefore gastric cancer. And B, there is a common belief, mostly from patients, that the long-term usage of PPIs is related to Alzheimer's disease. What is your opinion?
Well, I think first of all, it's important to recognize that long-term PPI should be avoided when possible. I think that there's always a risk-benefit. The international guidelines are pretty clear that individuals who are going to require long-term PPIs should be tested and treated for H. pylori. The testing and treating, I think, is pretty easy to do, but also to confirm that the infection has been eradicated, because there is this theoretical risk in certain individuals that they may progress, their chronic gastritis may progress to atrophy and gastric cancer. That's more common, I think, in Eastern Europeans or patients from Central and South America, and maybe Asian patients, not as common in Western countries in the United States. But I think it's still good practice to do that. Now, as far as side effects of chronic PPIs, and dementia has been the one you were concerned about, I think that probably is a biased observation. The studies that have looked at these complications have largely been population case control trials. There's been no prospective trial done. And the risk of things like dementia, kidney disease, heart disease, bone disease, probably is not as great as one, might expect by looking at the articles. There is some credence to the fact that chronic PPIs will lead to infections, such as Clostridium difficile and intestinal infections. It's important that we counsel our patients and give them the confidence that the medicines we're prescribing are generally safe, that there is risk-benefit. I think that there's this hysteria out there among some of our patients. They're very concerned. They stop the medicine because they read something in the newspaper. And I think it's our responsibility as healthcare providers to give them the appropriate information. And I try to counsel all of my patients that if they're going to require long-term treatment, then obviously we will monitor them for side effects, but they should feel comfortable that the medicines are generally very safe.
Right. I see. And we as a gastroenterologist, we must be assured that patient get cured from HP, right? Sure. So either any test that we have at hand, we should, prescribe the test in order to know if the patient was cured or not.
Sure. Yeah, I think the international guidelines are pretty firm on that people that are going to be taking chronic proton pump inhibitors should be tested and treated for H. pylori. And the testing and treating is important, but also the confirmation of a cure is important because, unfortunately, the therapies we have available for H. pylori are only going to cure infection 70% of the time, which
Right.
means that about a third of people that receive treatment are going to be, continue to be infected.
Right, and that's a major problem in South America.
Yeah.
In relation to HP, I know that Professor Barry Marshall, our common friend, was given the Nobel Prize in 1995. No, excuse me, 2005. Right. But before that, years before 2005, he worked with you at the University of Virginia. You were his boss. So the question is, did Barry influence you or did you influence Barry?
Well, I think it worked both ways. When I joined the faculty at the University of Virginia in 1990, Barry was there, and Barry, if you know him, sometimes has a difficult time focusing, and he's all over the place. So one of the things I think I did with Barry is try to focus him. And I was director of clinical services, so I did, oversee his activities. And I tried to protect his time. What I would do is assign him to clinics or various duties. It would still give him time to pursue his research and do his thing, so to speak. I also helped him organize his research activities at the University of Virginia. We collaborated and developed the C13 breath test and a variety of other things. But the reason I went to the University of Virginia when I retired from the Army was to work with Barry. So I can say that he had a big influence on me, but I think if you ask him, I think he probably said it was mutual, that we really helped and respected each other.
So about Helicobacter infection, what do you think is next? I mean, for the next decade, or what is coming for diagnosis and treatment of Helicobacter pylori in the world?
Yeah. Well, I think for diagnosis, we have good tests to diagnose the infection. I think there are ways now using PCR technique that it's going to be a little bit more sensitive in detecting infection and using different molecular techniques on biopsy material or even stool to determine antibiotic resistance patterns, because I think those will help us direct therapy in the future. I think there are going to be more potent drugs available to inhibit acid, and we recognize acid inhibition is essential for H. pylori eradication. So utilization of those more potent acid inhibitors, the PCABs, the potassium competitive acid blockers, probably is going to improve our ability and maybe even simplify our treatment regimens for H. pylori. But I think the future is really going to be vaccination. If we can come up with a vaccine that will prevent subsequent H. pylori infection, or possibly even a therapeutic vaccine, I think that's going to be the answer, because right now it's impractical on a population-wide level to test and treat everybody that's infected. I think the future is going to be trying to prevent the primary infection from occurring.
David, and how about, I know that esomeprazole acts helping the antibiotics to be more effective against Helicobacter. But how about a PPI, long-acting, I mean, covering 24 hours like dexlansoprazole, in order to increase the activity of antibiotics and reducing resistance of the bacteria. Do you recommend that, or should we, still using as a first-line therapy esomeprazole as a PPI agent?
Well, it's clear that the more potent acid suppression and the longer duration of acid suppression improves H. pylori eradication. Ideally, if you can keep pH above 6 for a 24-hour period, it's much easier to enhance the effect of the antibiotics that you're using. There aren't a lot of data with the longer-acting PPIs. In theory, I think using them twice daily for a short period of time during the H. pylori eradication would be helpful. And as I mentioned, the new class of drugs, the potassium competitive acid binders, they work very well, very profoundly in reducing acid. So I think that those would be probably our future therapies, either double dose longer acting PPI or a PCAB.
I see. And how about cost? In Latin American countries, dexlansoprazole, it's a little bit more expensive than...
Right. I think cost is always an issue, but the cost of not eradicating infection is much greater than the cost of initial therapy. So if you have a little bit more expensive therapy that works better, you're probably better giving it. The most expensive therapy is the treatment that doesn't work.
I see.
So you can have a very inexpensive regimen, but if it doesn't work, it's no good.
I see your point. I want to come back to talk about you as a teacher at UVA. I know that you were in charge of the morning rounds at UVA on Tuesday mornings, and you were called by residents the Big Kahuna, the Big Kahuna. What is that?
Well, I guess that's a name they gave me. A kahuna comes from the Polynesian as sort of the big boss or the king. So I'm big, so that's why the big came. And I guess they respected my clinical acumen, and that's why they call me the Kahuna. But I very much enjoy, in fact, that keeps me young, working with fellows. I enjoy mentoring fellows, and probably my greatest joy is working with the fellows and trying to impart some of my clinical experience from over the years to them. I still have fellows that I may have trained almost 3 decades ago call me, telling me how much they appreciated what I had done for them. And so, I think that makes it worth getting up in the morning, that you can really influence lives. I think we as gastroenterologists need to recognize that we have to instill a degree of professionalism in our practice. What happens is that oftentimes we're consulted not because somebody wants us to talk to a patient or give our opinion, but they want us to do a procedure. And that's a bad thing. I mean, we're physicians. We're physicians with a tool, and we're physicians first. So professionalism is extremely important. And I try to instill that in the fellows, the importance of talking to patients, touching patients. Now in this day and age of computers and electronic medical record, it's so easy to really avoid contact with people. And so to listen to people, empathize with them, and be humanistic in your approach to conditions.
I agree as well. I think I'm just one example of somebody has been impacted by your life. I met you in Mexico in 2007, I think, for the National Congress of the Mexican Society, and that completely changed my life. But I know that you have encouraged many physicians to do and to study gastroenterology because you're passionate about gastroenterology, and you have a lot of fellows and you've been the mentor of many, and I think you have really impacted their life. What is the secret?
Well, the secret is just doing what comes naturally. I mean, I was always brought up that way, that and Kristen always used to remind me that, the prime dictum is to keep your patients foremost in mind. So I think I give this example to the fellows. In many ways, I always ask fellows to make sure that when they're contemplating doing something, whether it be laboratory testing or some sort of diagnostic testing or endoscopy, to make sure they're actually doing something for the patient rather than just doing something to the patient. So we have many things we can do to patients, but are we really doing it, in the best, for the best reasons? So just being myself, I think, is the secret. There's nothing special. And giving practical advice. I may not be up with the latest science on everything, but again, I have a lot of practical knowledge, and I think the fellows appreciate that. And then they will bring that into their future practices.
Wonderful. Well, let me ask you about the 3 Ps.
The 3 Ps of the Peura presidency. Okay, well, when I was AGA president, I sort of had this mantra of the 3 Ps. And the first P was professionalism, and I just sort of alluded to that a little bit earlier, that it's important that we as gastroenterologists recognize that we're physicians first, and that we're physicians that have a tool, and we have unique knowledge that we can partake, but we should never look at ourselves strictly as an endoscopist. We should be physicians who perform endoscopy. The second P was political action. And I think it's important that we advocate for our patients, for access to health care, to make sure that everybody is able to receive excellent care. And the third was philanthropy. Philanthropy is something that has always been forefront of Kristen's in my life. Philanthropy doesn't have to necessarily involve giving money, but it's volunteering, giving time, giving other resources, and also giving money, really to pay back what other people have given me or given our family over the years. And that's very important because the future sort of depends upon what we, the present, are going to do, to guarantee. So to give money to facilitate research, or Kristen and I have actually sponsored a lectureship at Digestive Disease Week annually, just so that we can perpetuate medical education in the future.
And David, this is my last question. I know that you've been giving a lot to the society, to the humankind, to AGA, to your family, to your friends. But let me ask you, what do you believe at present time? What is your greatest legacy?
Well, I'd like to think that my greatest legacy lies in all those people that I've influenced over the years, that I've had mentored or trained, and instilled a little bit of myself in each of them. Many of these people, and for fellows, there's been almost 200 fellows over a 35-year career, that I've interacted with. And a little bit of me is in every one of those individuals. And as they relate to their patients and in their careers, I like to think that, you know, a little part of me is part of that interaction. Many of my trainees have chosen to continue in academic careers, so they're also doing research and influencing other people. So I think the accomplishments and the career successes of everyone who I've come in contact with and hopefully positively influenced, that's my greatest legacy.
Thank you very much, David. I think we're going to write this as an article in the Colombian Journal of Gastroenterology. We're going to upload this into the internet, YouTube. It's been a pleasure. So welcome back to Colombia again. And I feel very blessed having you here.
Well, thank you.
Thank you, David.
Thank you.